What we're going to talk about today is really, I understand that many of you may not know much about focused ultrasound. Some may not know anything about it. So I'm going to give a brief introduction as to what focused ultrasound can do. And then I talk a little bit about the FUS Foundation. And then I'm going to spend most of the time reviewing the current research status, which is where we are. And then I will go on to do a brief summary and have some time for questions for you at the end. And focused ultrasound is really the most powerful sound that you'll never hear, but a sound that could save your life. It's really, even today, an early stage, but it's a revolutionary, non-invasive therapeutic technology, and it has the potential to really be an attractive alternate or complement to existing surgery or conventional therapy. It has really, it's an outpatient procedure with no incisions and decreased complications from compared to conventional treatments, has a rapid recovery, and it could improve outcomes and lower costs. We discussed this kind of like it's been with MRI 40 years ago. It was really unknown, and now everybody knows of someone who has, or maybe you've had yourself, an MRI scan. Focused ultrasound today is really in the same situation. It's still unknown, referred to as medicine's best kept secret, but has the potential to revolutionize therapy. The principle is pretty straightforward. It's you just like a magnifying glass that will impact a leaf. You can use multiple transducers, aim them on the target, and they pass through the body without any problem. But then when they get to the target, that's where the energy coalesces and treats the condition. The thing about focused ultrasound is it's very good at treating the tissue with a very fine line between what was treated and what was not. So you can see on the left, there's images of the liver where you can see where it was treated and not, in a very strict line of where it was not. And even in the brain, there's a very tight line between what was treated and what was not. Now, there's a number of biomechanisms, and it's a busy slide. I won't get into it. It all depends on how you put focused ultrasound out and the way you're trying to treat the disease. And I'm really going to talk on just the ones that are furthest along. And it's really the destruction of tissue, delivering of drugs, opening of the blood-brain barrier, and immunomodulation. So if you're destroying tissue, there's really two ways you can do it. One way is you can use thermal ablation, which is the one on the left, where you just heat it up and burn it. Again, that's why the important part about having it be very precise is very important. But the other way you can do it is something called histotripsy, which is where you send a very short but very powerful wave, and it just disrupts all the mechanical components of the cells and have this slurry of the contents that remains. You can also use it to enable therapeutic drug delivery. And you know, for people who know about chemotherapy, a lot of the things that happens, it goes throughout your entire body and it impacts your entire body. Whereas if we can have the delivery just go to the organ that needs it, that's a big advantage. Here are some of the drug delivery vehicles. Some of them are very, very tiny, like 1 nanomolar, and larger ones up here that can hold a lot of contents inside. So there's a whole topic of the industry of the drug delivery vehicles, which we won't go into further. But the concept is this, that you take these microbubbles, and then they're about the size of a red blood cell, and then you infuse them into the patient. And so the patient has these in their body circulating, but they're not causing any impact to the patient because they're still contained. And then you hit them with focused ultrasound in the area that you want them to release, and then they release their contents, have their effect, and shrink the tumor down. Blood-brain barrier open is another interesting one where the blood-brain barrier was designed to be a protective area for the brain. It helps keep whatever is circulating your body from impacting the brain. So like if you get the flu, you don't want it to get in your brain, and so it's this added level of protection. But what that also means is sometimes if you're trying to get a therapeutic agent to help the brain, it has trouble getting there. So the idea of being able to do a focal area blood-brain barrier opening is really valuable, and it's especially valuable because it will actually reverse after you're done. So you can open it, and then about 24 hours later, it goes away. Now here's another busy slide that talks about all the things that are out there being worked on, and it starts with the green and goes to the US reimbursement, which you can see there's not a whole lot of reimbursement out there now. It's really just essential tremor, tremor-dominant Parkinson's disease, bone metastases, prostate conditions, and uterine fibroids. But there's a lot of work behind the scenes going forward to bring focused ultrasound to treat a lot of different conditions. Another way to look at that is, back in 2006, there were only 3 items that people were really working on, and now there's over 135. Another way to look at it, if you look at the treatment for essential tremor, and remember the treatment for tremor-dominant Parkinson's disease is exactly the same treatment. It's really increased dramatically just in the last few years. And here's a treatment of an essential tremor patient, just so you know. This is a left-handed architect who has a lot of problems beforehand, moving jelly beans from one side to the other. There's his performance on the straight line and circular drawings. Here's an image of his brain, and the blue dot is where you want to target to hit this patient. And so this patient was treated. And again, this is awake, no anesthesia, no incisions. There's a spot, it's a little hard to see, but you see the red arrow pointing to that where they got to. There's his straight line and drawings afterwards. And here he is a month later, moving the jelly beans from one to the other. Here's a case where a patient had uterine fibroids, substantially sized. She could have surgery, recovery time, or she could have focused ultrasound, which she picked. And there she is about 9 months later after the fibroids were treated and then they resorbed into the body. Here's a patient with pancreatic cancer. And you can kind of see that this is the area right here that we're aiming at. After treatment, you can see how it's turned kind of a darkened color, which is, it got a large portion of the treatment. And even it regresses over time. And here's some remaining tumor, 22 months later. Desmoid tumors are a benign disease, but they're also very malignant in the way they behave because they tend to recur and involve organ structures and nerves, et cetera. Not a good place to treat this. This was treated with focused ultrasound and had an outstanding result. Breast cancer is another area that is under investigation. You can see the tumor here in this patient, and there's the tumor effectively treated with focused ultrasound. Here's a young patient that had a pelvic tumor, and she actually tried doing surgery on this patient, and they had to abandon the surgery because they didn't think she would survive. They had too much bleeding. They treated her with focused ultrasound. You can see kind of the darkened area where they treated initially. This was enough to get her kidneys functioning again, and they came back and treated the rest of it. She's now 9, and she's surviving, doing well. And basically, this tumor is likely to reoccur because of the nature of where it was, but it will then be treated when it becomes symptomatic at that point, whereas before she really didn't have a good alternative. And here's someone who had treated for prostate cancer. You can see the entire tumor here is involved, and after it's treated, there's basically a spot where it was. There's not really much there. The PSA has gone down to next to nothing, and there's a very small volume. So that's kind of a background about focused ultrasound. Let me tell you a little bit about the foundation, because it's kind of an interesting story as well. The way we look at it is, the sooner this can get adopted, the sooner we'll be able to help patients. But it takes a long time for these things to go through and get adopted. And so our goal is to try to put the research together to save the time, to help save the lives along the way. And as you know, when you have a new technology, especially not a drug, but a technology itself, there's a lot of impediments, regulatory approvals, differences in the way the physicians look at it, referral patterns, et cetera, many challenges. And Dr. Cassell, my boss, he saw this because he was involved in the Gamma knife, which is another technology that was relatively new. And he saw that took 40 years to get to the point where it was readily available. And he said, I can't watch that happen again. And so he was looking for what is a way to help move this forward. And he really couldn't find one. So he said, all right, we're obligated to invent something. And that invention is the Focused Ultrasound Foundation. And we're a unique organization that is truly designed to try to just help move the process along. We do research. A lot of what we do is early stage research to help move the process forward. And we also do some education, which is kind of what I'm doing now. And we also help with advocacy working in the federal government. Our mission is really just to accelerate the development and adoption of focused ultrasound to make it a global standard of care. Now, we do a lot in terms of spreading of information. We have a newsletter, and I bring this up because at the end, I'm have a listing there, and I would suggest that you all sign up. It's totally free. It comes via email, and it tells general information about clinical trials, but it also talks about new developments in the field in general, as well as the new clinical trials that are out. We have had a number of media placements that are out there, so we're trying not to make it medicine's best kept secret. One of the people on our board that really helped with this is John Grisham, and he wrote a book about focused ultrasound. It's a non-legal book that kind of describes how this person would deal with glioblastoma now and how it might be changed by focused ultrasound. And that really had a lot of people become aware of us through that and come to our website because of it. And we also work with other organizations, so we're not out here all by ourselves. We try to partner with other people, and we've worked with the Michael J. Fox Foundation. You'll hear a little bit about a study that we did with them coming up. How are we funded? It's really by donors, and we have fortunately very committed donors. And our goal is just to bust through all these impediments to get this accomplished. Now I'm going to spend a little bit of time here on the current research status. So right now, the FDA has approved focused ultrasound for treating tremor-dominant Parkinson's disease. And this happened a few years ago. I think it was in the end of 2018. And it's now the treatment for tremor-dominant Parkinson's disease, the target is the ventral intermediate nucleus. And that's important because that's exactly the same as essential tremor, which got approved by the FDA a couple of years earlier. And so this kind of piggybacked on the back of the FDA approval for essential tremor. And here's the reference to the major article. And a lot of people believe that when some device gets approved by the FDA, it's good to go and you can go out and get it. But it's really not the case. You have to really go through Medicare, and then the commercial insurance usually will follow that. And it takes time. So even though this has been a couple of years, Medicare is now covering it in all the states listed here. Now, it's interesting that the way Medicare, even though Medicare is a national organization, there's these Medicare audit contractors, or they're called MACs, that cover several states. So you can see, even in states where they don't have a focused ultrasound device, like Georgia or Alabama, they're still listed here because they're in a group that has approved it. But the other thing that's interesting about this is that if you lived in Georgia and you wanted to go, say, to North Carolina, where there is a device, and get treated, you could. And we believe that Medicare will pay for it. Now, this is something I say you always need to confirm that with the treatment site to make sure that what I'm telling you is accurate, because Medicare changes its rules all the time, but the bottom line is it's located, the payment is based on where the treatment is given, not necessarily where the patient lives. So that type of possibility is out there for it. Now, for commercial insurance or for co-insurance, you have to check and see by the individual ones, because there's just too many of those for us to know about that. But that's something important to remember. Now, the FDA also recently improved dyskinesia. And I use the word dyskinesia kind of as a family of things, because there are a number of events that can happen, and they're kind of lumped into dyskinesia. And dyskinesia is really involuntary movement of parts of the body, but it also includes some rigidity and some other things that impair mobility. And the target for this is the internal portion of the globus pallidus. And we're going to talk about that a little bit more in a minute. Now, this is interesting that the publication of this study, which had over 90 patients, has still not come out, but they shared it with the FDA, and the FDA has already gone ahead and approved it. But so we're waiting for the publication to come out, and also waiting for the steps for insurance coverage. And just so you know, there are some international approvals, both for tremor dominant and for dyskinesia. Now, this is a little bit of a busy slide, but part of it is there are several locations you can treat in the brain to treat dyskinesia. One is the globus pallidus right here, and you can see where the nerves pass through in this drawing. And the other one is the subthalamic nucleus right here. And the other one is the pallidothalamic tract, which is as these nerves flow up this way past the thalamus, which is over here. So I wanted you to think about that, because we're going to talk about each one of these things briefly. So again, I'm talking about the pilot study, because the pivotal study that got the FDA approval hasn't been released yet. So this is, it was published in 2020, but it was actually, the study itself was back in like 2017, 16, et cetera. It's a unilateral treatment of 20 patients. And the key part is the movement portion of the UPDRS, which is a standard scale, improved by 45% from baseline, and it lasted for 12 months. And the p-value, the p has to be kind of less than 0.05. And this is a much lower number, means it's very statistically significant. Here's some results of their studies, and the key one is right down here, where you see and the lower scores are better for this here. So this is where they are at baseline. It dropped down here at 1 month, 3 months, 6 months, and 12 months, and stayed down. And I appreciate Dr. Eisenberg shared this slide with me. Now, in terms of side effects, they didn't have any serious adverse effects by the FDA criteria, but there were a few patients that had adverse events which they rated as severe: sonication pain for 2 patients, and 1 had nausea and vomiting. Most of the side effects tend to be mild and transient, but not all of them were transient. Some of them lasted even at 12 months. The other target is the subthalamic nucleus. That was the next one that we showed moments ago. And this treated 40 patients, and this was published in the New England Journal of Medicine, and there's a reference. And their UPDRS3 improved 52% from baseline, was also preserved at 12 months, highly significant p-value. Here's a design of it. This group of patients, some had a sham procedure where they had everything appear like they were having the treatment, but it wasn't actually done, just to track that and compare that to those that had the treatment. And then the sham patients could go down and join this other group later. They had some side effects in this group as well. And remember, this is 40 patients now, but they had a little bit more. 15 patients had speech disturbance, 13 had gait disturbance. But a lot of these were transient, and many of them did not last to the end. But again, not all. The next group is the pallidothalamic tractotomy, and this is the one where they that tract that was going up the side of that diagram we showed moments ago. And this is even a larger study of 50 patients. Now, not all of them were tremor dominant. This was a mixed group where they had some rigid patients and other interventions. But then they had a similar result. 54 patients had a result, very consistent p-value. Here's their diagram, and again, remember it was very consistent dropping of the baseline to the 3-month and 1 year. And they also had some side effects. Again, many of these were short-term, but there were some that lasted at 12 months. So a couple of things to note: the symptoms did not resolve completely, and that's important to know because these assessments are very good at getting very fine levels of disability, and they can see that. But when you talk to the patients who have this, most of their symptoms that impacted their activities of daily life got much better, and they're very, very happy with the results. But the other thing to think about is what happens with the ongoing progression of Parkinson's disease, because as you all know, it's a disease that keeps getting worse over time. And that one we really don't know the answer yet because it just hasn't been around that long. We have had some patients that have had recurrence of some of their symptoms, and they have had retreatments of some of these. So it's not like radiation therapy where you have one treatment and that's all you can get for your life. You can go back and retreat the same area again, and that has had some good results, but we haven't had any publications or large numbers of this. So this is still something that's still kind of a question that needs to be answered as we're going forward. So a lot of patients have bilateral disease. And so there's some effort working on treating patients bilaterally. And I listed the one up here for essential tremor because remember, that's the same target as the tremor dominant Parkinson's disease. And for all of these, what they're doing is a staged treatment. So they treat one side, and then 6 or 9 months later, they treat the other side. These are all trials that are happening now. And you can see the one under essential tremor at the second one down, my mouse seems to have stopped working here, is just completed their enrollment. So we should see something on that soon. And then the Parkinson's disease ones, there's a couple of groups going forward for that one. And noticeably, they're going forward with the PTT, that last one, for Parkinson's disease. And so there's a lot of continued questions for movement disorders. You know, if we're doing bilateral treatment, do we need the same technique on both sides? What staging is really needed, if at all? The reason they're doing the staging is because when they were treating patients with open surgery and they did both sides, because obviously they don't want to go into the brain a couple times, they don't have to, they had a lot worse side effects. And so they're doing the staging just to let the swelling and stuff settle down, but it may not be needed, but they're just being cautious with it for right now. And then what lesion size is optimal? And this is really important because if you have a larger lesion size, your efficacy gets better, but then you have more side effects. If you have a smaller lesion size, you might risk your effectiveness, but your side effects go down. And that weighs into this other one is what's the optimal targeting technique? They usually use traditional coordinates, which is how neurosurgery has been done for a long period of time, but that's based on kind of an atlas of we know this part controls this in everybody. But the part about using MRI tractography is where you do basically high density resolution of the patient being treated themselves. And so now we're not steering toward what the atlas says, we're steering toward this patient precisely. And the goal there is people believe that if we can make this more personal, then we can get to the target spot exactly in the patient. Then we can have a smaller target size and have it be effective and have the win of less side effects. So everything I've talked to you up till now on Parkinson's disease has really been the symptoms of movement disorders. Not getting at the underlying cause of Parkinson's disease, but what about treating those symptoms? And another big symptom with Parkinson's disease is cognitive impairment. And there's been some work done with Alzheimer's disease that says if you can open the blood-brain barrier, some of the metabolites and things that are kind of stuck in the brain can get out better, and some of those patients do a little bit better. So these folks tried opening the blood-brain barrier in patients with mild to moderate cognitive impairment just to see if they could do it safely And also they did a whole bunch of tests to see if there were any impacts on their cognitive function. And what they found was they could do it safely. Again, very small study though, only 5 patients. And they did these testing and they found that there were improvements in different areas in different patients. So even the authors were very concerned and said, look, this is not saying like this solves the problem, but it does say we can do it safely. And we did see some improvement. So we need to do some more studies on this, which is obviously very exciting. And then going at a little further to say, what if we really tried to get at the underlying cause of Parkinson's disease? And actually there are 2 groups that did something and they released it in October, exactly the same time. And we actually have this link here is to the article about that we had in our newsletter. And this information will be shared with your group can have this when we're done, so you can go see these links. But basically, the group in Spain found that they could open the area that's felt to be the initial area, which is the striatum. It's a part of the brain for Parkinson's disease. And this is important because a lot of the blood-brain barrier opening had been over kind of non-eloquent, non-motor areas. And this is an important area that they weren't sure if there was going to be problems or if it was going to work well or not. And they found they could open it and they could open it repeatedly. And this hasn't been published yet, but it's in process. So that was one group. And the other group was looking at a little bit of a different group of patients with Parkinson's disease who also had a reduced production of this glucose cerebrosidase, which is a metabolic enzyme in the brain. And they were trying to open the striatum on one side, and they tried to do it in patients who did not have this enzyme, and they gave this IV Cerezyme, which is basically a replacement enzyme, to see how it would impact these patients. They didn't have any problems. Again, only 4 patients were done, and it hasn't been published yet. But we do know that they felt it was so good that they've already gone forward with starting the second study, where they're doing both sides of the brain, and they're increasing their dosing. So we're waiting for this to get published. And so the important thing on both of these is that if we could use the blood-brain barrier opening of focused ultrasound to put in therapeutic agents to help stop or reverse the Parkinson's disease process, that's the win that everybody's trying to go for. And there's some people working really hard on it right now. So in terms of steps for underlying cause, there's still a lot, right? There's, what agent or agents, when to give it, how long will it last, what location or locations, what kind of timing needs to be done. A lot of questions still need to be answered. So it's, a lot of what we're going to be doing in our newsletter is trying to go at these types of things. But it's exciting that we're on that process. So now just a brief summary. For our foundation, you can see the black line went up there. That's how long it would normally take for this to be reached, to reach widespread availability. And what we're trying to do is just move that line to the left under the green, the green line that's there that says if we can move it to the left, all those lives of those patients can be improved. And that's what we're trying to do. That one image is what keeps us going day in and day out. Because really for us, it's all about the patients.
When I first heard I had Parkinson's, I was very surprised. I always thought of it being an older person's illness, and I've always seen people in wheelchairs. So I thought I was going to lose all my mobility. Basically anything that required movement, I couldn't do it. My leg would bounce uncontrollably. It would hyperextend and actually lock backwards. It was very, very painful. I couldn't walk, so I had to be taken in a wheelchair to the hospital. With each treatment, I could feel myself getting stronger and stronger. My symptoms were getting less and less, and my pain was getting less. Then the clinical trial director, she looked at me and she says, "Get up, you can walk." And I thought, I can walk. It was amazing. I got there in the wheelchair, unable to walk, and immediately following it, I walked to the room. It was a miracle. The Focused Ultrasound treatment has given me back my life. I've been able to go on walks, I've been able to run, being able to ride my bike again. It was a miracle.
And with that, we can end and do some questions. I put this slide up here because it has my email address there. Also, the sign up page for the newsletter. Again, totally free, just sign up and it'll be sent to you a couple times a month. And if people are looking for treatment site locations, this is a link that will take you to the treatment site locations in the US.